Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Crystal Merducanes, clinical instructor teaching critical care nursing. For today's topic, we will be continuing the response to altered ventilatory function, which we had discussed on our previous lecture video. So as continuation to our topic, we have the airway suctioning. So first, let's define suctioning. It is a method of removing retained secretions or other semi-liquid fluids from the patient's airway. And it works via the application of a negative pressure to the airways through a collecting tube or catheter. So how suctioning works? It can be applied to either the upper airway or the oropharynx and the lower airway, which is the trachea and bronchi. The access to the lower airways is performed with a flexible suction catheter through the nose or artificial airway. So as you can see here in the picture, we have an artificial airway, which is an endotracheal tube, and a flexible suction catheter is being inserted inside that endotracheal tube in order to suction pulmonary secretions. So what is the normal suctioning pressure? So remember that our goals here are to ensure that it is strong enough to remove the secretions, and it is not dangerously strong enough to cause damage to the airway. So please remember these two goals in setting up your suction pressure. So we have here a general rule of thumb. Remember that the suction pressure should be set at the lowest effective level. We have two types of suction equipment. First is your wall suction. For adults, the suction pressure should be set from 120 to 150 millimeters of mercury. For children, the suction pressure should be set from 100 to 120 millimeters of mercury. And for infants, the suction pressure should be set from 80 to 100 millimeters of mercury. We also have the portable unit. For adults, the suction pressure should be set from 10 to 15 millimeters of mercury. For children, the suction pressure should be set from 5 to 10 millimeters of mercury. And for infants, the suction pressure should be set from 2 to 5 millimeters of mercury. So remember that we have two types of your suction equipment. We have the wall suction and portable suction. And it has a different suction pressures per age bracket, depending on the type of equipment you are using. So how to estimate the proper size of a suction catheter for patients with endotracheal tube and tracheostomy tube? So you have to multiply the tube's inner diameter by 2, then use the next smallest size catheter. For example, let's say you have a size of 8 mm endotracheal tube. So all you have to do is to multiply it by 2, which then gives you 16. So you would use the next smallest suction catheter in French units, which would be a size French 14. So what are the indications for suctioning a patient? If you noted that the patient has an absent or decreased chest movement. Also, if the blood pressure of your patient fluctuates. If the patient has bradycardia or low heart rate, decreased tidal volume, inability of the patient to generate an effective cough, increased peak inspiratory pressure, increased work of breathing, and low oxygen saturation. It is also indicated to monitor the efficacy of a treatment. Patients with artificial airways, such as endotracheal tube or tracheostomy. Presence of coarse crackles over the lung area, and presence of aspiration. Also, if the patient has recent history of large amounts of thick or tenacious secretions, especially if patient has a condition called cystic fibrosis, wherein the pulmonary secretions are very thick, which the patient could hardly expectorate. Also, we have respiratory distress due to copious amount of secretions. Also, if you noted a sawtooth pattern on a flow volume loop on the ventilator monitor, as well as tachycardia or increased heart rate, and visible airway secretions. So now let's proceed to the contraindications for suctioning. So if the patient has basal skull fractures, so we would not suction our patient. Also, if the patient has cerebral spinal fluid leak, epiglottitis or croup, because the tendency here is when we manipulate our epiglottis, the tendency is it would close permanently. Facial injury as well, hemodynamic instability, increased intracranial pressure. Remember that when we suction our patient, we impose stress or pressure to them. So that would in turn increase their intracranial pressure. Loose teeth, denture, or crown. Okay, because that could be a source of aspiration. Also, if the patient has nasal bleeding, because this could further increase bleeding tendencies, as well as occluded nasal passage and recent facial surgery. Severe bleeding disorder, severe bronchospasm or laryngeal spasm, severe gag reflex, and tracheoesophageal fistula. How to determine the effectiveness of therapy. So if you noted to your patient that there is a decreased work of breathing, as well as improved blood pressure, improved heart rate as well, and improved respiratory rate. Also, if you would note the improvement in breath or lung sounds, increased oxygen saturation, also there is presence of chest movement and removal of copious amount of secretions. So these assessments are your indicators that your suctioning is effective. So what are the risks and hazards of suctioning? So the patient might experience abnormal heart rhythm. Also aspiration, bleeding as well, and suctioning can stimulate the vagus nerve and thereby resulting to bradycardia. Changes in intracranial pressure, gagging, and vomiting. Also, the patient might have laryngospasm or bronchospasm from suctioning. Lesions in tracheal mucosa, low oxygen levels. Remember that when we suction our patient, we do not only get the pulmonary secretions, but also we suction oxygen. And thus, it results to low oxygen levels of our patients. Also, it could result to lung collapse, mechanical trauma to the airway, and the patient might experience pain and other discomforts, and respiratory arrest. Now we'll proceed to the artificial airway management. That includes your endotracheal intubation and tracheostomy. So first, let's define endotracheal intubation. Endotracheal intubation is an emergency medical procedure that is performed on patients with altered level of consciousness or an impaired breathing pattern. It helps maintain an open airway and prevent respiratory arrest. And it also allows for continuous medical intervention while prolonging the life of the patient. And it is performed by skilled and licensed doctors or respiratory therapists while nurses assist during the procedure. So how does the intubation process work? Well, it provides mechanical ventilatory support to the patient in order to keep them stable while the underlying cause is treated. In a typical endotracheal intubation, patients are given anesthesia and a muscle relaxant in order to minimize discomfort and relax the muscles of the airways. And during the procedure, a laryngoscope, which is a device designed for visualization of the vocal cords, is used to hold the tongue aside. And a flexible plastic tube will then be inserted into the trachea through the patient's mouth. The tube will be then secured by inflating the small cuff around it. And pressure is often applied to the patient's Adam's apple to significantly lower the risk of aspiration of stomach contents. And placement is initially confirmed by inflating air through the BVM or the bag valve mask and listening to breath sounds on both sides of the chest. Also, chest X-ray is done to confirm the tube placement. So what are the other considerations? Normally, pediatric patients require a much smaller endotracheal tube than older adults, and inserting the tube may require skills and experience because ET tube placement in smaller airways needs a higher degree of precision. The process of endotracheal intubation is the same in patients of different age brackets. The only difference is in the size of the equipment used during the process of insertion. In some cases, healthcare providers use fiber optic scope, which is a device used to enhance or enlarge images to allow better visualization and easy insertion during the process. So now let's proceed to the indications for intubation. Endotracheal intubation helps maintain a patent airway. This procedure allows air or oxygen to pass freely to and from the patient's lungs during respiration. This emergency medical procedure is indicated for the following. First, to open the airway so that the patient can receive a sufficient amount of oxygen, prescribed medication, or anesthesia. It is also indicated to protect the patient's lungs and to help patients who stop breathing or those with impaired breathing pattern. And it helps patients who require mechanical ventilator achieve spontaneous breathing. It is indicated for patients with head injury who cannot breathe on their own. And it is performed on patients who require sedation for a period of time to allow recovery from a debilitating medical injury or serious illness. Now you might be wondering, what is an endotracheal tube? An endotracheal tube is a flexible plastic tube that is inserted into the patient's mouth, into the trachea or windpipe to help sustain spontaneous breathing. The ET tube is then connected to a ventilator or a bag valve mask to provide patients with continuous oxygen delivery. The process of inserting an ET tube into the airways of the patient is known as endotracheal intubation. The ET tube comes in various types and sizes. The size of the ET tube can be determined by the inner diameter. For example, if the inner diameter is 8 millimeters, the tube size is also 8. Now let's determine the difference between the cuffed and uncuffed ET tube. When we say cuffed ET tube, it requires an injection of pressurized air into the balloon to create a seal against the inside walls of the airway. On the other hand, the uncuffed ET tube is recommended for children less than 8 years old to prevent narrowing of the trachea. So I have here a picture differentiating the cuffed ET tube and the uncuffed ET tube. Now let's proceed to the post-ET intubation care. So after the endotracheal tube is secured in place and the patient is connected to a mechanical ventilator, the doctor and registered nurse will continue to monitor the condition of the patient, the tubing and settings. Treatments, oral care, and suctioning are essential in order to maintain a patent airway and sustain spontaneous breathing. Due to the location of the tube, it is important to keep in mind that conscious patients will not be able to speak while the ET tube is in place. At this point, we will now differentiate orotracheal versus nasotracheal intubation. When we say orotracheal intubation, it involves the insertion of an endotracheal tube through the patient's mouth and into the trachea. It is performed more frequently than nasotracheal intubation. It is also indicated for the maintenance of a patent airway of critically ill patients with multi-system disease or injuries. It is also indicated for the control of the airway of patients undergoing general anesthesia. On the other hand, nasotracheal intubation, also known as blind intubation, involves the insertion of an ET tube through the nose and into the trachea. It is performed without using a laryngoscope to view the opening of the glottis. This technique may be used without extending the head of the patient. Therefore, it is recommended for patients with spine injuries and clenched teeth. So what are the medications used for intubation? Prior to endotracheal intubation, your doctor may administer the following medications to facilitate easy insertion and maximize the effectiveness of the procedure. First, we have your atropine. This drug works by increasing the heart rate while decreasing bronchial secretions, thus facilitating the easy insertion of your endotracheal tube. Also, we have your vecuronium. A small dose of this neuromuscular blocker is given in order to prevent muscle twitching caused by full doses of succinylcholine. Succinylcholine also relaxes the muscles of the airway to facilitate easy insertion of the ET tube. Also, we have your benzocaine. It is a topical anesthetic used to reduce discomfort associated with endotracheal intubation. And lastly, we have your etomidate. It is used to sedate patients during the process of intubation. So now let's proceed to the rapid sequence intubation. So what does RSI mean? It is considered as the fastest and most effective airway management technique that makes use of induction agent and muscle relaxant to induce prompt unconsciousness and paralysis, allowing healthcare providers to insert ET tube with minimal delay. So here are the indications for RSI. So if there is an airway burn, cervical spine injury, combativeness, hypoventilation, hypoxia, impaired gag reflex, major trauma requiring multiple medical interventions, penetrating neck injury, prolonged transfer, and swallowing difficulties. So what are the complications of intubation? So we have here first the short-term complications. So aspiration of contents of the mouth or stomach, bleeding as well. Esophageal placement of the tube, injury to the mouth, teeth, tongue, thyroid gland, larynx, trachea, vocal cords, and esophagus as a result of the procedure. Lung collapse, your pneumothorax, temporary hoarseness. Also, we have here the long-term complications. First is allergic reaction to anesthesia. Breathing difficulties, difficulty speaking or swallowing, facial swelling, fluid buildup, pain in the neck, severe sore throat, spinal cord injuries, tracheal stenosis or the narrowing of the trachea, tracheoesophageal fistula or the abnormal connection between the trachea and esophagus. Also, we have your tracheomalacia. It is the flaccidity of the supporting tracheal cartilage. And vocal cord paralysis. Now let's proceed to tracheostomy tube. So what is a tracheostomy tube? It is an artificial airway that bypasses the patient's upper airway and is inserted directly into the trachea via a stoma. The tube is most often made from silicone or polyvinyl material. When a patient no longer needs the airway, steps can be taken to wean them off the tracheostomy tube before it is eventually removed and the stoma itself can be closed. So what are the indications for tracheostomy? If the patient is unable to protect their airway, and if the patient will require mechanical ventilator for more than 1 or 2 weeks. And if the patient can't manage their own secretions and require frequent tracheal suctioning. Or if the patient has a difficult airway or sudden trauma or swelling in the upper airway and attempts to intubate via the endotracheal or nasotracheal have failed. So how is tracheostomy tube inserted? Tracheostomy, which is the procedure that creates the opening or stoma in the patient's neck where a tracheostomy tube will be placed through, are performed by surgeons or doctors. In a traditional surgical procedure, surgeon will sedate the patient and use a local anesthetic such as lidocaine to numb the area where the tracheostomy will be created. A 3 to 4 centimeters incision is made in the patient's neck and tools such as bronchoscope, introducer needle, and a dilator are used to insert the tracheostomy tube. So how tracheostomy tube is placed? Tracheostomy tubes are placed level with the second or third tracheal rings. It should be big enough to occupy 65 to 75% of the diameter of the patient's trachea. So now you might be asking, what are the risks and complications of a tracheostomy? So we have here first infection. Also, pneumomediastinum if the tracheostomy is false track. Damage the larynx or trachea, such as tracheal or laryngeal lesions, the formation of granulomas. Also, obstruction to the tracheostomy tube from secretions or blood clots that prevent ventilation. And accidental decannulation of the tube might occur. Tracheomalacia as well. It is the collapse of the airway when breathing. And tracheoesophageal fistula. So how does tracheostomy tube work? A tracheostomy tube works by allowing the patient to breathe through the tracheostomy tube that has been inserted into their stoma, bypassing their upper airway completely. Because patients with tracheostomy tubes are not breathing through their nose and receiving natural humidification, either a heat-moisture exchanger or another device delivering humidification to the airway is required. So now let's proceed to the different parts of a tracheostomy tube. First, we have the outer cannula, which is the outer structure of the tracheostomy tube. We also have the faceplate. It rests against the patient's neck and prevents the tracheostomy tube from going completely into the patient's trachea. It has slots in it for tracheostomy ties to secure. Also, we have inner cannula, a cuff, and a pilot balloon. It is used to inflate the cuff. And also, we have an obturator. It is used to prevent damage to the trachea during insertion of the tracheostomy tube and removed immediately after insertion. So here is the complete parts of your tracheostomy tube. So we have your outer cannula, the cuff. We also have the cuff inflation line, the pilot balloon, the inner cannula, and obturator. We also have here the plug or a cap. Now let's discuss the fenestrated tracheostomy tube. Fenestrated tracheostomy tube has a hole above the tube's cuff. It allows airflow through the patient's upper airway. This hole, combined with removal of the patient's inner cannula, can allow airflow through the patient's upper airway. Capping a fenestrated tube with the inner cannula removed and the cuff deflated can allow you to gauge the function of the patient's upper airway. When a patient has a fenestrated tube, they are at risk of developing granular tissue at the site of the fenestration. If your patient has started growing granular tissue, you will likely notice some bleeding from their airway or signs of airway obstruction. So it is very important that when your patient has a fenestrated tracheostomy tube, you need to monitor for bleeding. Because if the patient has bleeding, that could be an indication that there is an airway obstruction caused by the development of your granular tissue on the whole of that fenestrated tracheostomy tube. So how to perform tracheostomy care? So first, you have to gather and check all required equipment. And you have to suction the tracheostomy. And you have to cleanse or replace the inner cannula. Inspect and clean the stoma. And replace the patient's trach ties. And lastly, you have to perform a patient assessment after tracheostomy care. So what is a cuff tracheostomy tube? Cuff tracheostomy tube serves either allowing the delivery of positive pressure, ventilation, or reducing the risk of aspiration. Pressures that are too high can cut off mucosal blood flow, cause tracheostenosis, or other damage to the patient's airway. Pressures that are too low may reduce the effective delivery of positive pressure ventilation or not fully protect against aspiration of secretions. Small balloons towards the end of the tracheostomy tube that will expand and fill with air until the cuff reaches the tracheal wall. Appropriate cuff pressure of either 20 to 30 millimeters of mercury or centimeters of water should be maintained. On the other hand, uncuffed tracheostomy tube is a tracheostomy tube that doesn't have the balloon at the end of the tube. These tubes are most often used in the neonatal population or for patients who don't need mechanical ventilation and can manage their secretions effectively. Also, we have your cup tracheostomy. So what is a cap tracheostomy? It is a tracheostomy tube that has been covered or occluded with a cap. It prevents air from moving through the tracheostomy and forces the patient to breathe through their upper airway. It is used also to test if a patient will be able to breathe without their artificial airway and potentially have their tracheostomy removed. and it's also used to let tracheostomy patients speak. So you might be wondering, can you talk with a tracheostomy tube in place? As what we have said or discussed earlier, capping or covering a tracheostomy tube will force air to go out the patient's upper airways and allow them to use their vocal cords, thereby allowing the patient to speak. However, because of occluding the tracheostomy tube causes an increase in airway resistance, some patients may not be able to tolerate this. Alternatively, a speaking valve can be placed on the outer portion of the tracheostomy tube. These valves allow air to pass through the tracheostomy and valve on inhalation, but do not allow air to pass through the valve on exhalation, forcing the air through the patient's upper airway and enabling them to speak without occluding the tracheostomy tube.